Journal Club series, we talk about a recent publication in head and neck imaging. Today, we're going to talk about Ecchordosis Physaliphora. If you ran into this image on a T2 weighted MRI of the skull base, here we have a pretty well defined T2 bright lesion that is cratering into the center of the clivus. This is a classic appearance for what we have called for many decades Ecchordosis Physaliphora. So the old paradigm for this disease is that chordoma is the malignant version of a notochordal remnant, whereas ecchordosis is the benign version of a notochordal remnant. This has been a fantastic model, except that it's entirely wrong. This really doesn't fit the way this disease works. Here's how we look at it now. Notochordal remnants are on a spectrum of aggressivity. It goes from completely benign to very aggressive and malignant. But the line between benign and very low-grade chordoma is too narrow for radiologists or even pathologists to clearly draw a distinction. Pathologists for years now have stopped trying and call these benign notochordal tumors for both low-grade chordomas and for Ecchordosis Physaliphora. It's time for radiologists to follow suit. So we needed a new term. And the term that we're using now is benign appearing notochordal remnant. This is a radiologic term as opposed to a pathologic term, benign appearing notochordal remnant. And you can treat these either with observation to determine the rate of growth, or you can go ahead and excise them and make sure that you're not dealing with something malignant. If it grows at all, it's not ecchordosis. It's a low-grade chordoma. Here's an example. Here's the well-defined bright object right smack in the center of the clivus. CT on the same patient. It has all the features of Ecchordosis Physaliphora, including the arrows on this little spike of bone running through the center of the lesion. That's supposed to be very specific for ecchordosis. But here's the problem. This is a low-grade chordoma. It has all the features of Ecchordosis Physaliphora, but it's fooling you. And that's why we can't trust the imaging appearance. We have to rely on the behavior of these tumors. Here's another example. In 2015, I interpreted this lesion as Ecchordosis Physaliphora, benign, no danger. The patient comes back in 2021 with headaches, and this lesion is bigger. It's a very slightly bigger. 6 years, just marginally larger, but it is still bigger. And when we resected this, it was called a low-grade chordoma. You can't trust that appearance. This works the other way too. Look at this nasty looking clival lesion. Of course, we're going to call this a chordoma, this heterogeneously enhancing lesion in the center of the clivus. So we advised resection. When it came back, the path said ecchordosis. You just can't win here. You have to call these things benign appearing notochordal remnants. I'm not even sure I would have called this one benign appearing. Would have just gone and called it a chordoma. So bottom line, stop using the term Ecchordosis Physaliphora. Instead, use the term benign appearing notochordal remnant. Then you can observe the benign appearing lesions, decide whether or not they are enlarging over time, and treat them based on their behavior rather than their radiologic appearance.